All right, good afternoon, everyone. We're excited that you've carved out times from your busy schedules to join us for an important affinity group session this afternoon, focused on maximizing physician support for cardiac rehabilitation. There was a time not too long ago when it was hard to get physicians convinced of the value of cardiac rehab. And our general impression is that that has improved a lot over the past 5 to 10 years, and that's excellent. But having said that, maximizing physician support is a matter of going from okay to good and from good to better. And our panelists today, I think, will provide you with some very concrete, tangible ideas that can help you do that. Just to extend the welcome from the Take Heart team. Take Heart is a project that's funded by AHRQ, and CDC and the Million Hearts Group are closely connected with and supporting our initiative. And so we all want to join in welcoming you and thanking you for your time. Just a couple of updates on Take Heart. There's a third group of programs that are currently working to improve care coordination, to maximize the participation in cardiac rehab. And that's an important initiative, and we want to acknowledge their efforts on the final cohort, which is now begun. There's also a work group of about 15 programs that are involved in some way in cardiac rehabilitation and hybrid cardiac rehabilitation that's working together as a group to help us produce a resource that's focused on that topic. Hybrid cardiac rehab is an option that may help you to recruit more patients that ordinarily would choose not to participate or not be able to participate in cardiac rehab. And it can get them in and support them safely and effectively as they work to strengthen their heart and deal with the cardiac challenges that they're encountering. So that's going on. And by the end of the Take Heart project in December, we will have that resource available. Now, if you're just kind of wondering about other resources available from Take Heart, those are all contained on the Take Heart project website that you have the link for here in the slides. We will be sharing the slides from today's event afterwards, as we always do. As far as today's event, all of these affinity groups provide forums for you to learn and share and support each other. And all of those things are important in what we know is a very challenging environment. Today's affinity group session, we want to continue that process of learning and sharing with a special focus on maximizing physician engagement. So, and our panelists have some great insights that we've learned a lot from in preparing for today's event that we're eager to share with you. So this will be a moderated panel discussion using the chat feature so that we can make sure that we are engaging with you as the audience during today's event. Now, the chat feature is very easy to use if you haven't used it before. As you look at your screen to make a question or to comment, you can just open the chat box and make sure that you set the field to everyone so that both the panelists and all of the other audience members will see your questions or comments. And feel free to respond if someone else asks a question or makes a comment that you can assist them with, and we will try to do the same throughout the event, or bring up the question or the comment so that our panelists can discuss it as well. So try the chat function if you'd like. Say hello to everyone. Tell us one thing that you're looking forward to hearing about on today's call that caused you to dial in. So that's a great way to get us started and make the event as participatory as possible. I'm delighted to introduce our three panelists today. Caitlin King is the Transitions of Care Coordinator for Cardiovascular Critical Care Services at the University of Kentucky Healthcare. Christine Bryant is the Cardiac Rehab Nurse Manager at Prairie Heart Institute at HHS St. John's Hospital. And we're delighted that she's joined us along with Marion Harris-Barter, who's the System Director for Cardiac Rehabilitation at Lee Health. And all of them have direct applied experience with the topic that we're going to be discussing today. Now, just to get you to know our panelists a little bit further, let's start off with an opening question. related to the backgrounds of our panelists, as well as how they would characterize the physician support that they encounter for cardiac rehab in their institutions. So let me turn first to Christine. And Christine, just tell us a bit about your program as well as how you describe the level of physician support for it.
Hi, thank you, Stephen. Good afternoon, everyone. Yes, as Stephen said, I'm the nurse manager over the cardiac rehab and heart failure departments here at my hospital. We're a large teaching hospital located in central Illinois, about 3 hours south of Chicago, and we're actually closest to the St. Louis area. We serve both local and rural patients, and we're very lucky to physically be in the same building as our closest physician partners, Prairie Cardiovascular Consultants. We have a 7-day-a-week phase 1 inpatient service and phase 2. And we also, of course, have a maintenance program as well as a PAD program. I'd say we have a good collaborative relationship with our physicians. I think they appreciate cardiac rehab as a specialty, and they trust us to provide competent care to their patients. I think that stems partly from the fact that I have longevity with my staff in my department. Most of the cardiologists, they know my staff very well, and they know and trust their quality of their work, frankly. So I feel like that definitely helps, you know, them to feel confident that we'll do what we need to for their patients.
All right, thanks very much. And we'll draw on your expertise throughout the call today. Let me turn to Marion. Tell us a bit about your program and physician support for CR.
Thanks, Stephen. Good afternoon, everybody. So our program, we are the only healthcare system currently in Lee County in Fort Myers, Florida. We also serve Cape Coral and the surrounding areas as well. So we have 4 main hospitals and 3 big outpatient centers. And we have outpatient cardiac rehabs in 2 of the hospitals and then in 1 of the outpatient centers. We also have inpatient cardiac rehab at 3 of our other hospital facilities. We're averaging still around 70 to 80 patients a day in 2 of the facilities and probably about 40 in the other in our outpatient program. I think the biggest thing about the physician support is really, you know, as Christine was saying, is being there with the physicians, developing that rapport with them, making sure that they know what your outcomes are, and those types of things. So we've had really great support from our physicians. Some of them took a little bit longer than others to come aboard, but I would say right now we're really doing well with our physician support.
All right, thanks very much. And just to acknowledge Laura's question, we are going to talk a lot about the kinds of evidence and data that physicians can be influenced by. So it's a great question and one that we are eager to get to in just a few minutes here. But let me draw in now our third panelist, Caitlin. Your reactions to the background of your program as well as level of physician support for it.
Hi, thank you for having me. So I am at the University of Kentucky Healthcare in Lexington, Kentucky. We are a large facility, a big transfer facility, so we do service local and majority of central and eastern Kentucky, as well as outside, a little bit of West Virginia, Tennessee, etc. Our cardiac rehab offers phase 2 and then a maintenance wellness program. We don't have a traditional inpatient phase 1, but we do have care coordination liaison, myself, to visit patients at bedside. And I would say our physician support right now is probably the best that I've seen it in the last 9 years or so. And I think that's a lot to do with the work that we've put in to be in front of the physicians. Echo what the other 2 have already said, is just you know, just being in front of them, physicians see what other physicians are doing, so they kind of follow suit, and just showing them the great work that we do in cardiac rehab.
All right, thanks very much. And I think already one of the themes that you're hearing from our panelists is that physician support for cardiac rehab is not something that you get instantaneously by waving a magic wand or even using a single piece of evidence or article or anything like that. It's really a growing process that you have to work at. Over an extended period of time to just build that gradually. And I think that we're going to get some great ideas today on the best ways to do that. So looking at the strategies that we're going to touch on, all of these things directly relate to how you maximize physician engagement. But just to simplify things a bit, we're going to talk about those things in 5, general buckets. Making contact and engaging with physicians. If you can't do that, then your arguments are never going to make any difference. Using data is really critical, and we want to hone in on that issue. Responding to objections is important, and that's where we're going to draw in, among other things, the insights that you shared as you responded to a registration question about the common objectives that you encounter. And then fourthly, we'll talk about how to encourage productive physician visits. We've heard again and again the value of getting the physicians actually into your cardiac rehab unit so that they can actually see what's going on there, be impressed by your staff, be impressed by your equipment, being impressed by the level of monitoring that you do. So we'll talk about that. And then finally, we want to just focus especially on the issue of traditionally underrepresented populations. There are women and other groups that just aren't as frequent participants in cardiac rehab. And that's really an area that we want to improve and that the Take Heart project is focused on. So we want to get our panelists' insights on all of those issues before we finish off today in about 45 minutes. So let's start with the first of these issues, strategies for making contact and engaging with physicians. And if you think about that, really there's a few aspects of that I'm going to ask our panelists to respond to. One is, who does this best? Because there are some different people that you might use to engage with the physicians, and then what methods work the best, and then also when and where is the outreach most, and for that matter, least effective. So those are all important questions, and let's get the focused conversation on this first question started. Let me go back to Marion and just ask you for your reactions to the strategies for making contact and engaging, and what you've done that's worked, and conversely, what have you done that you realized wasn't as effective for you?
So I think I said it last time too, but I think the most important contact we have with engaging physicians when we're face-to-face with them is in the hospital and with our inpatient nurses. That way they can follow up with the physicians, if they have questions about the patient or the care that would, be best for the patient to continue in cardiac rehab or start in the outpatient program. We also do follow-up calls from our inpatient setting, and we've actually had quite a bit of success when we call the patients after they're discharged from the hospital, finding out there's medication errors or changes that the patient didn't adhere to, and following up with the physicians then to get the patients on the right track as far as whatever it is, medications or care. And that has been really successful because it's developed the relationship between us and the physicians and their patients. So I think that those methods have really worked well. The other thing that we did is our surgical patients in our hospital actually come into, there's a surgical component. The office is right in the hospital setting, and we put one of our nurses there too. So after they've had their follow-up surgical visit, they meet with the cardiac rehab nurse again. So even though we've scheduled their outpatient appointment, it's really been beneficial because a lot of times patients don't remember, as we know in the hospital, exactly what's been said to them. And even though we've given them the paperwork, they may not have remembered us discussing with them outpatient cardiac rehab. So that has been very beneficial to us as well, and getting those patients that maybe had been scheduled but were kind of on the fence about coming because they didn't remember what it was about, or didn't really know all the ins and outs of the program. And so there we actually discuss it with them, tell them more about it, and get them secured in their outpatient appointments. And I think the last thing is our medical directors have been so supportive, and any concerns that we might have, any policies that we have questions about, we can take to them. And then they're really great at going to our other cardiologists or our surgeons and bringing up those questions to them and getting the answers we need. So I think those things have been very supportive of our program and helped our program a lot.
All right, thanks very much. And let me turn now to Christine. What would you add to Marion's suggestions?
So I would definitely echo what Marion said as far as face-to-face on the floor contact with the patients. We may not, the physicians may not necessarily solicit information or ask for our views on how their patient is progressing. We actually initiate it. We talk to the physicians and let them know, what these are their thoughts about phase 2. They may be on the fence, or they're definitely going. So I think because we take that initiative to communicate with them, I think they appreciate that. And also just being able to report out our data with support from my service line manager, or director rather. I'm a standing agenda item on the Department of Cardiology quarterly meeting. So I try to make sure I have great data to share, maybe even data the physicians didn't even know they wanted to know. So, so that's how I try to make sure I'm in front of them, myself, and then also my staff on the floor. And the great thing is at this Department of Cardiology meeting, I'm able to multitask, if you will, in regards to just spreading the word about this service, because other than the physicians at that meeting, there's also other service line managers and leaders. Our CEO attends. So it's a great platform to be able to talk about the good that you're doing.
Thanks very much, and some of the important insights with respect to who to work through, because you can't always influence cardiologists or other practitioners directly. Sometimes working through established channels is a very effective strategy. And let me turn now to Marion. Your thoughts on what you've done that has supported your efforts to make contact and engage with the physicians.
So Steve, I already went. I think it's Caitlin that we need to hear from. That's okay.
I'm trying to vary the order, and I knew I was going to botch it, so I'm kind of glad I got it out of the way early on, and now we can just not worry about that and go on to Caitlin.
No worries, thank you. So again, I have to echo what both of the ladies said, especially Christina, about getting in front of those quarterly meetings. We also do that with our physicians. We are not always a standing appointment, but we do try to work ourselves in there somehow, even if it's a 10-minute window. Sharing data, one of the best, I think, data points, not directly data, but just making sure that all those physicians know that cardiac rehab is a class 1 indication, and it does, it's just statistically proven to reduce readmissions. And it's not just exercise, it's more than that. It's a comprehensive program. We have a large fellow presence here. So in July, when our new fellows come on board, we do make sure that it's included in their rounding that they visit with cardiac rehab. Even if it's only for a 5 or 10 minute stay, it really, just so they can see the facility, see that we do offer telemetry monitoring and nutrition education. It's not just exercise. So face-to-face is the best, like everyone has said.
All right, thanks very much for those insights from the three of you. Now let's turn to our next question, which is using data, which is really critical, and it's come up already a couple times, and we're going to go to Marion and Caitlin and finish off with Christine, who's going to show us a few examples of the kind of data and how she shares that. So Marion, what data is the most influential and what methods are you using to share it? And, you know, is there anything about how you portray it visually that you found works better or worse for engaging with physicians?
So we share our data with our medical directors on a monthly basis, but we also post our outcomes and in the department. And so it's there for the patients to see. And I think the biggest thing is how the patients feel and the outcomes that they have, you know, from being in the program that they've received. When they share that with the physicians, that is so influential because, you know, the data is great to see, but if their patients are telling them how much better they're doing and how much better they're feeling, that is really, really important. So we make sure that we do share all our outcome data. We certainly, I think the biggest thing right now is looking at for our system, and I think a lot of systems, is readmissions. We're really working a lot on decreasing readmissions, especially with our heart failure population. So that data is shared, like I said, on a monthly basis with everybody involved in readmissions within the system and our heart failure patients and their outcomes as well.
Thanks. Caitlin, what about the data that you share? And in particular, if you'd like to comment on whether you try to use any of the patient satisfaction data to bolster the case with your physicians.
Absolutely. So we always show referral data, the amount of patients that come through the hospital that qualify, how many of those were referred, and then how many of those actually attended. They're always interested in that. And we also benchmark that against national averages so that they can see we are doing a little bit better than national averages. They're always excited about that. And then, as Marion said, the patient data is always, patients to share is always great. We do provide our patients, if they have a cardiology appointment at any point during their stay with us, a printout for them to take to their physician so they can show them exactly what they're doing and all their improvements. And, you know, the physicians are always excited and happy to hear those patients, you know, praise us, for lack of a better word. And then it's just when the physicians come to visit us, we do have a patient success story book that they are able to look through as well. So that's always helpful.
Just as a follow-up to this, I mean, there are some places that try to, you know, show physicians comparative data so that they can see how they compare to their peers. Do you do any of that? Do you find it useful? And do you have any tips on things to either do or avoid doing as you share that sort of comparative data?
We keep all that data. We have not shared that data. A lot of ours is based off really, referrals are kind of based off who's on service that week. So it's really, other than the clinic, I don't know that it would be helpful to them. We obviously keep the data so we know there's better people or better physicians that refer from clinic than others, but we have not shared that to this date.
Christine, what about you? Do you kind of share that sort of comparative data with your physicians?
You know, I don't currently. We do have a lot of other hospitals with our other sister ministries that have a cardiac rehab program with that are in our system, and it would be interesting to actually see among all the system programs, you know, where everyone is at, because it does really, if my hospital, which is considered the flagship hospital, we send so many referrals out to them. It's interesting. It would be interesting to see the trend when things are, whether it's cases or procedures are down here, how that affects them down the line. And that, you know, it doesn't just affect us here, but also our other outlying hospitals that we refer to.
Yeah, and certainly as everyone on this call is aware, for the last 2 years, data is really hard to interpret just because, you know, with program closures in some places and with patients reluctant to come on site due to COVID concerns, you know, there's not too many indicators that you could be looking at that would not be really affected by some of those historical trends. But as we hopefully emerge into a more stable period, looking at that and using that sort of data can be very useful. So, but Christine, there is data that you do share with your physician. So why don't we take a look at one of the things that you shared with us, and why don't you talk about, you know, what's represented here and how you use this and how physicians react to it.
Sure. So I've shared different types of data through the years, but you know, the thing that I always seem to go back to all the time is really just around enrollment. They really want to know, you know, how many of their patients are complying and coming to our program for more support. So here, the data here is actually something that I compiled specifically for our participation in the Take Heart program as a partner hospital. And I have to owe my AIM statement to help me sort of focus this, because it was very overwhelming to think about, you know, what types of data should I be sharing. So what I ended up doing was breaking it down based on enrollments per month. And so our overall goal is to increase the number of enrollments by 5 to 6 patients per month over what we did the last calendar year over the same period. So I was able to go back and look at calendar year 21, and then of course, you know, updating as we go along for calendar year 22, and sort of see in comparison, you know, where we're at compared to last year. And I think just as a visual, it really, you know, makes a great visual for the physicians to see, you know, because perhaps they can associate our big jump in January with, you know, a very busy cath lab month, for example, or CVOR schedule. So this is sort of what I've been sharing more recently. And the thing that I also thought, you know, that was important, because I only have about a 5-minute time to really share information about my department. I want the data to just be very simple and very straightforward. So I think that this type of data does the trick. And so in the next slide, just as an example, this is where I've also broken it down, you know, in sheer numbers, so that, you know, the physicians can also see totals, and then side-by-side comparison with the numbers for each month. And on the next slide, I've also broken it down by, we have 5 total classes that we offer in phase 2, and I also, this is interesting for us operationally, just to see how many patients prefer any particular class time. And also at the bottom there, I've also included, you know, any no-call, no-shows. Of those, how many were rescheduled. I think that's really important information to have as well. And actually just recently, because we just had our quarterly meeting, I'm going to actually now add the number of outlying hospital referrals we facilitate on a monthly basis. Typically, we're in the 60 to 70 range as far as patients per month that we will refer out. And so I think that's another data point that I think sort of gives the physicians the full picture.
Thanks very much. And I think that, you know, this illustrates so many things that we can't go into all of them, but, you know, there clearly are seasonality things where some people are avoiding, you know, surgeries or big things in December. So you see more of a surge in, you know, January and into February. And, you know, some of those months could easily be affected by, you know, when you, in particular, you might have had recent COVID surges. So it's going to take a while, but I would encourage you to do what Christine is doing, which is to make sure that you're looking not at single months at a time, but looking at it sort of as a composite, because that really helps you to maintain a better big picture of what you're doing. So thanks very much, and by all means, if you have questions as we go through this, put or comments or reactions, or you have your own data thing that you'd like to share, by all means, let us know in the chat. We'll be happy to acknowledge those comments or questions and get our panelists to respond to them. All right, let's move from data sharing to physician objections. And as I mentioned before, we asked each one of you as you registered for the event to tell us the most common objections that you need to overcome to cardiac rehab coming from your physicians. And the results of over 100 of you are reflected in this graphic. And, you know, this last one of cardiac rehab isn't important and can be done independently. We hear that over and over again. And so we're going to have our panelists comment on responding to that specific objection. But then you also see that, you know, some of these others, people aren't interested or able to enroll, is a common objection. And that's one where, you know, sometimes inadvertent stereotyping, you know, you assume that somebody can't attend or won't attend because their background may be similar to others that haven't attended in the past. And that kind of stereotyping can really negatively impact some of your patients. And we want to make sure that we're avoiding that. And even though the concerns about the health of the patients are not are the least common, still 10% of you indicated that your biggest concern was patients being healthy enough for cardiac rehab. So that's what you've told us, and now we want to turn to our panelists to get their reactions to this. And let's start with Marion on this one. How do you decide where to focus your efforts when you're dealing with objections, and how do you respond to some of those common objections, as well as how do you work through other people to address the concerns that people have?
This is a really good question. I think that for us, just the leadership in our hospital system has been really important for us to get the support from them. And they have been very supportive of our program. And I think, again, then just to share that cardiac rehab is just not an exercise gym. You know, there's so much more. It's a comprehensive program, a lot of education, a lot of behavioral modification goes into it. And I think the more that you can share all the things about cardiac rehab with your leadership in the system, and then again, physicians, is what's important. Again, getting those patients to go back to their physicians and say, this was so much more than I thought it was going to be. You know, I learned so much. I now feel not only stronger and better, but also I'm, you know, I'm eating better. I'm just able to know what my exercise limitations are and be able to do that. And I feel confident now that I can continue this on my own. But it is difficult, and I really think that we still have some physicians, you know, the patients will be doing well, and they'll go back to see their cardiologist, and they'll say, well, now you're doing so well, you don't need to go back. And, you know, just that constant, no, this is a program. We don't want people to, because we know that research shows the more sessions that patients have, the better outcomes that they, you know, in the long term they'll get. So we really want our physicians to let our patients continue with the program, finish the program. And I think focusing efforts on just physician education about the program. Again, I know we're going to talk a little bit later about getting physicians into the program, seeing it, but I think making sure that they're aware that this is a program, it's not a gym. I think those are some of the most important things.
Yeah, thanks very much. And as a follow-up to that, why do you think sometimes physicians that, you know, see a patient that's improved, why do they say you don't need to continue? I mean, is it trying to save them money if they have a copay, or what would prompt them to tell somebody that they could quit or should quit?
Again, I think it's just unknowns of what the program, you know, the goals of the program are. They think it's just to get them exercising on maybe not all the other things, the components of cardiac rehab. They're not familiar with the other components. So I think it's mostly just, you know, the lack of knowledge about what a cardiac rehab program entails and the benefits of doing the whole program. So I think that's mostly what it is.
All right, thanks. Christine, your approaches to these objections, and in particular, I think that a couple of you, when we were preparing this for this event, you know, made the point that sometimes the physicians to target aren't necessarily the ones that are the strongest objectors, but sometimes they may just be ones that are sort of on the fence, and you can wind up spending too much time, you know, with the person that you're never going to convince, and not enough time with the ones that, you know, you really have a more opportunity to influence. So what would you say about your approaches to responding to these objections?
Well, I think the biggest thing that we can all do in terms of dealing with these objections is really just to spread the word about what the program is, what it entails, what our objectives are when helping our patients. You know, and that starts not just with the physicians, it starts with you know, their mid-level providers that work with them. They oftentimes have a little bit more time than the physicians to listen and really be there and understand what's going on in our cardiac rehab gym. I also think, you know, having nursing students come through just to have some kind of exposure to this program, you know, the more that you can expose, have healthcare providers, you know, exposed to this program, just to know that it even exists, I think is the best way to try and deal with objections that might come. But you're correct, though. In my experience, you know, there were physicians that when I first started were just adamantly against any cardiac rehab involvement. Our order on the order set for phase 1 was pre-selected, so they had to physically uncheck it for us to not get involved. And so that, to me, is a very strong feeling towards cardiac rehab or not supporting it. So, you know, and to me, I decided to look at it, you know, that's fine. That is that person's opinion. And I chose to really focus on the physicians and even the mid-level providers who are our biggest supporters, and they far outnumber those that don't support us, you know, trying to help those providers that are on the fence, that just aren't sure what we do, and they're neither unsupportive or supportive. So I think really putting your time in for those folks that, number one, do support you and have supported you from day one, to the folks that are on the fence, that's better time spent to me. And, you know, in my case, that specifically, that physician or physicians that were not supportive, they've retired. So they're no longer, you know, here to you know, cause us some grief. So I think that's just the best way of to spend your time.
Yeah, thanks very much. And I think, Christine, you make a really important point about making the right thing to do, the easy thing to do. And you know, that's a mantra in healthcare as well as, you know, other industries. But you know, this is one of the many values of having an automatic referral system, is that nobody needs to, you know, to go through the process of seeing whether they had the right, you know, ICD-10 codes, or whether they met the right conditions for reduced ejection fraction, to be eligible for cardiac rehab. The easier the process can be to help them identify who really should be enrolled, and the easier to, you know, to encourage them to just, you know, leave well enough alone, as opposed to, you know, having to take an extra step in order to refer someone, the more successful you're likely to be. So those are really important insights. Let me turn to Caitlin now. Your thoughts on how to respond to some of these objections.
Yeah, so we've also received objections and had people on the very far end of the scale who absolutely refuse to refer or tell their patients, you don't need to do that, even though you qualify. From talking with others, I think it was a complete lack of misunderstanding of what cardiac rehab could offer and what did offer. We have a wonderful medical director right now, and I would say that his lovely words of us definitely help his peers refer, because they are pressured, I guess, maybe a little bit to compete and to do the same and kind of take part in this wonderful program that we offer. So just by having him as an advocate for us on that same level. And then I would also say just the objections from the physicians can also be helped from, I know we've said like advanced practice providers, but also like heart failure coordinators or case management. People that work in the clinics with those physicians are a great resource to add in and say, hey, let's add on cardiac rehab referral for this patient from the clinic.
Yeah, thanks for those additional insights. And, you know, I think that sometimes too, if you're focused on the heart, you lose track of the benefits of cardiac rehab for the entire patient. And, you know, it might be that the most valuable things that the patient is getting from the cardiac rehab is the confidence that it's okay for them to exercise, and the belief that they really can improve their diet. And those things may be a little bit out of what you're focused on if you're just looking at, you know, ejection fraction, or whether or not, you know, the heart is pumping as well as it should be. But when you think about the whole person, that's a broader frame, and cardiac rehab clearly has many benefits for the whole person that go well beyond just the, you know, because if you have eating challenges, there could be other contributing factors to that, emotional stress, all sorts of things like that you frequently address in your education programs. So casting that broader frame may also help you to deal with some of these objections. All right, let's turn now, just as we want to encourage you in the chat, as you think about these objections, if you have strategies that you're using to respond to some of those objections, or if you have other additional objections that you're struggling with or that you're dealing with, but you've come up with good solutions for, by all means, put that into the chat so that you can share that with your peers. Let's turn now to the issue of physician visits to your facility. If your facility is like adjacent to the hospital or in the hospital, this is a bit easier. If it's not, it's a bit harder. But let me turn to our panelists and just get their tips on how you can get those physicians to come, as well as what the most important things for you to do are when they do come to make a favorable impression and reinforce their support for your cardiac rehab program. Let's start first with Marion on this question.
So I think the great thing about the guidelines is that medical directors have to, well, our medical directors come in actually to the facility to sign the ITPs on a daily basis most of the time. So that does get them in the facility. And we've actually encouraged them to come not at the end of the day, but during the times that the sessions are going, so they can visibly see the patients. If patients have questions, that they can be there to answer the questions. That doesn't always work, but if it does, it's a great opportunity for the patients to see the physician involvement and for the physicians to see the patient involvement as well. I think, again, like I said, we do post our outcomes and they're very visible. So when the physicians are there, they can see them. We haven't been as successful as both Caitlin and Christine in getting our other physicians necessarily into the centers. One of our programs is in the hospital, but it's in a, area that is not easily not easy for the physicians to get to. It's not that visible. And then another one is in an outbuilding, which is across the street and down the road. And then the other one is, like I said, in an outpatient building. So physicians don't generally come into the facility. If we can't get them, if we have new cardiologists that do come into the system, however, we do always invite them to come and see the facilities if they have any questions, to follow through with them on those types of things.
All right, thanks very much. Let's turn next to Christine. Your approaches for encouraging productive physician visits.
Yes, so our closest collaborators are cardiologists just upstairs. When they onboard a new physician, the executive VP has tried to make it part of their onboarding that they, of course, tour the facilities, and just recently adding cardiac rehab as a stop on the way has been really helpful. We're sort of tucked in the back of the building on the first floor. Nobody knows sometimes that we're here. So just having those newer physicians just at least have that basic knowledge of where we're located, I think that has definitely helped. Again, as Marion said, having the physicians that do sign our ITPs, right now, one actually comes sometimes after hours if she needs to come and sign our ITPs, and the fact that she feels that comfortable to come in and get that done, I think because we were so very happy to have her help, but she feels comfortable enough to do that when we're not here, and just being able to as we've all said already, all three of us, that we need them to understand that this is more than exercise. The patients can talk to someone about their diet, can talk to somebody about their stress, and that this is a lifestyle change program. This is not an exercise program. I think just being able to get those words out, as soon as they get into the doors is extremely important, because of course we know that's such a misconception. And then lastly, just really making sure they understand that when we take care of their patients, it's all they're all treated on an individual basis. we try to meet their needs specifically as much as we can, and it's not just, you know, everyone's going to do exactly the same thing for 10 minutes and then, you know, and then we move and shift to somewhere else. We really like to tailor it, and they need to understand that that's a normal part of cardiac rehab.
All right, thanks very much. We got a great suggestion and question from artists in the chat. Apparently they use videos with patient testimonials that they show in the physician break rooms and try to circulate to the physicians. And then there's a question about do you have physician open house events? So of the three of you, how many of you have tried that? Did it work? Any suggestions on open house events to draw physicians in?
So, sorry.
Go ahead. Christy.
Oh, thank you. I was just going to say at my facility, I do allow employees to exercise in the gym after hours. So that's always another thing to draw them in as well, if they know that, you know, they have all this beautiful equipment that they can take advantage of. I've actually asked some physicians when they would be able to come and perhaps lead a warm-up for class. I haven't gotten any takers yet, but I think that would be a great thing for them to see, you know, patients in the process of going through this program and how well they're doing, and being able to experience it literally with them. So I'm going to keep trying, but hopefully I can get a taker.
All right, and then Marion, your quick assessment of physician visits before we move on, because I want to make sure that we have time to talk about underrepresented patients.
It's Caitlin's turn again.
I just wanted to know. I was just checking on whether you had
open houses.
Yeah.
We have not had open houses. We did when we opened at all our facilities. We have one newer program that just opened. Well, a newer facility that opened in the last couple of years. And when we open, we do have an open house, but I have not done that on a regular basis. And I think that's a great idea, though.
And Caitlin, what about you?
We have not hosted open houses. It sounds like a great idea, though.
Yeah, and these events, the panelists share ideas with the audience, and the audience shares ideas with the panelists, and everyone benefits, which is exactly as we would like. Let's move on now to our last question. We know that underrepresentation in cardiac rehabilitation is a significant problem, and if you're younger or older than the normal cardiac rehab patient, or if you're a woman or Black or Hispanic or less educated, or if you're lacking insurance, all of those groups tend to be less likely to be participants in cardiac rehab. And the evidence that you see on the next slide, this is just a screenshot of one of many studies that shows that underrepresentation is associated with poorer outcomes and higher mortality. So this is definitely an issue that we want to deal with. And so let's turn now to our panelists as we look at this. How do you raise the issue of underrepresentation, and what are you doing to expand the involvement of underrepresented patients? And let me start off this one with Caitlin. Your thoughts on how to deal with this important issue.
So I encourage physicians, whether they're on the fence about referring for any number of reasons, a patient, just to put in the referral. We will contact them and work through any kind of issues the patient may have. As far as co-pays and different things like that, we have found our philanthropy group to be extremely helpful. And we've also had quite a few very grateful patients in the past who were willing to donate money to a fund so that we are able to assist patients with high co-pays to attend, or underinsured patients as well. So that has been extremely helpful for us.
All right, great. And then Christine, your thoughts on what you can do to promote expanding participation with these underrepresented groups?
Yeah, so we're definitely early on in the process of, evaluating our current pool of patients, who's missing, who's not represented. So we know, though, that it's very important work and we need to put a lot of focus on that for sure. Right now, as Caitlin said, the foundation at our Prairie Foundation that we work closely with, they've been a great resource for us. And what we decided to do really was the lowest hanging fruit as far as, patients that might have barriers to coming was really transportation barriers. And so right now we're working with our foundation, especially now with gas prices, on being able to help those patients have that barrier and hopefully remove that barrier with gas cards, bus passes, things like that.
Great, and there's a very similar comment from Sylvia in the chat about using bus passes as well as gas cards to help with that. So great ideas, helping the patients to do what they would like to do, but frequently I have financial challenges to doing. Mary, let's finish off with you. Your strategies for helping to expand participation from underrepresented groups.
Yeah, so with the automatic referral, we do automatically get all the referrals for all the patient populations that would be eligible for cardiac rehab. So we do reach out to all those patients that have barriers, whether it be insurance, transportation. Our system contracted with a taxi service to be able to get those patients that didn't have transportation. Some days that works out better than others, but it has allowed patients that perhaps, don't have transportation or have issues with that to be able to come. The other thing that we've done is worked with the system, developing a group for women, specifically for women and heart health. So we go visit the women in the hospital, give them a little blurb, but there's a little package that they have designed especially for women to be able to, target them and get them into the program. We actually do have a lot of women in our program right now, so that's been beneficial. And I think then the other thing is working with some of the foundation or some of those things to help identify what the barriers are for these patients, and then figuring out ways that we can get them into the program.
All right, thanks very much. And we could go on talking about this topic or any of them for an extended period, but we are coming up on 3 o'clock at Eastern time. And if you have additional questions or comments, by all means, put those into the chat. We're not going to be able to respond to them orally here, but we do frequently incorporate them into the follow-up materials that we produce. There are additional resources on physician engagement, both at the Million Hearts website and on enhancing care coordination and physician buy-in that are available on the Take Heart website in several of the training modules that we use. So by all means, reference those things if you can. And then just looking ahead as a reminder, we do share the event materials, including the slides. All of those things will be circulated. And we have future affinity groups that we'll be having. One of those will focus on hybrid cardiac rehab, but if you have other suggestions for topics, by all means, let us know. We take those suggestions really seriously. So thank you very much. If you have some additional feedback, we'd really appreciate it if you'd respond to the few feedback questions before you exit the event today. We really appreciate and want to thank our panelists again for their excellent insights, and to thank all of you for taking some time to learn about this important topic this afternoon. So thank you all very much, and have a great rest of your day.